So it's great to be here. As Tony said, I'm an alumni. I'm very, very proud of that. The Anderson School really launched my career. This is something that I will be forever grateful. So for those of you here who are students, you are in a very, very good and enviable place. And I also want to thank Emma for asking me to speak and Robert and Ike for helping me prepare for this. It's always a little bit harder than it should be. So for those of you, well, probably not any of you, but for anybody who's heard me speak, one of the things they know about me is I love telling stories. I think that we can explain very complex and very nuanced issues through storytelling. So throughout today, I'm going to tell you a number of stories. Some are my stories, some are other people's stories, but they all matter. All the people that we talk about in here matter. These stories matter. They're all unique in their own way. And they all paint a picture of an industry that is in desperate need of reinvention and transformation. So I hope as you go through this and you listen to that, you'll see that. And you'll see that in those stories. And you'll think about your own stories in your own life, in your own personal life, and in your professional life that have made a difference and can help you tell that story to others and encourage others along this transformation journey. So as we get going, I want to start with one story. And that story is Sharon Woodard's story. So here you go. I don't know if we don't have the sound on it. Maybe.
I ran up big medical bills. They're still on my credit report, and it's got to be a good $20,000, if not more. I mean, I've had to go to food banks. I've had to do things that I never, ever expected was going to happen in my life. It hit like a lightning bolt. I was actually laying on the couch watching Project Runway, and it felt like someone put a gun to my shoulder and shot. And it hurt so bad. The next morning I ended up in the emergency room because I could not change my clothing. I was sitting in pajamas. They pay you an inordinate amount of money to do it. I was making upwards of $80,000 a year. It doesn't matter how much money you make because it can be taken away from you. If you get sick, the medical bills are going to come. I saved as much money as I possibly could and quit. I ended up living through all of that money and having to sell my car. I did what I needed to do to make sure that I had a roof over my head and food in my stomach. I had to go live on my friend's couch before I finally got disability in my early 50s. Finally went to a drug called Enbrel. Here's the thing about these drugs. They're super expensive. Without insurance, you're going to pay at least $1,800 a month. Enbrel worked for me, but it was really expensive and I had to find the funding to do it. I made pretty good money. I was doing really well. And then this happened, and it devastated me with everything. People say, you know, to pull yourself up by your bootstraps, go to school, get a good job. I did all of that. I did that, and I still ended up with nothing.
I've seen this video just preparing for this, probably no less than 10 times. And I will tell you, every time I see it, it gets to me. This could have been any one of us. Sadly, Sharon's story is not unique. There are thousands of people in the United States facing what she has. Despite the fact that 90% of Americans now have access to some form of health insurance, whether that be commercial insurance or through a government program, medical debt remains a persistent problem in this country. Approximately 14 million people in the United States, adults, or 6% of adults, owe $1,000 or more in medical debt. And about 3 million people owe $10,000 or more, like Sharon. Polling has shown that people with excessive debt often go on to not eat healthy foods, to substance abuse, to cut on other essentials, take on more debt, and drain down all of their savings, which is exactly what happened here. The fact is, most Americans don't have enough liquid debt or liquid assets to handle the deductibles and copays that come with insurance, let alone the unexpected expense that might come if you become sick. This belies the entire problem, really, if you think about the healthcare system, and it really shows you what we're solving for. When you look at the headlines just over the last year, they paint an undeniable picture of an industry in desperate need of reinvention. Not just innovation, but fundamental reinvention. And some might argue that this is a system that needs to be unwinded, completely reinvented, and it certainly is a system begging for innovation. So when you look at these headlines, Tony talked about health equity. We simply cannot accept a system where infant mortality for Black babies is 2.5 times for white babies. We cannot accept a system like that. And when you look at the stress of poverty, discrimination, trauma, coping mechanisms such as substance abuse, these all ultimately contribute to lower life expectancy. And we'll see that later. When you look at communities that might be 5, 10, 15 miles apart, the differences in life expectancy here in Los Angeles is something that we just simply cannot accept. And we must also understand that health equity is not just a moral imperative, but it is a business imperative and it's a financial imperative. A recent study done by Deloitte showed that health inequities in the United States today cost us $320 billion. And that's due to things like differential in diagnosis, treatment, and overall health outcomes. And is it projected that if this is left unaddressed, that this will reach $1 trillion. The cost of health inequity is $1 trillion by the year 2040. We know, for example, that Black adults are 60% more likely than white adults to be diagnosed with diabetes and experience complication at a rate 2 to 3 times higher. People living below the federal poverty line are more than 50% more likely to have asthma than people earning higher incomes. These are real issues. These are not, just moral issues or ethical issues. These are fundamental issues for our communities and for the business of healthcare. The other thing that was interesting, there was also a recent Deloitte study looking at women, and they were looking at women adults with employer-sponsored coverage. So this is some of the best coverage that you can have. And it showed that women pay 20% more out of pocket than men do for the care that they receive. And if you take out maternity care, because I know everyone here is going to say it's all to do with maternity care, that only drops to 18%. And this is already on top of a very significant and persistent wage differential where women earn about 84 cents on every dollar that men earn. This is not an indictment of men, but it shows how equity shows up in people's lives. I don't think I need to tell you how significant environmental issues are, but it is imperative that we continue to talk about sustainability as a health imperative. About 1 in 4 people in the United States, more than 119 million residents, live with pollution that can harm their health. While some improvements can be made and they can be traced back to things like the Clean Air Act under Nixon, still 64 million Americans live in counties with failing grades for daily pollution. That is unacceptable. And of the counties with the worst air quality, 72% are residents with people of color. Again, health equity is a real issue. And we cannot accept this as tolerable, ethical, and we also can't accept it as unchangeable, because it is. In 2023, the fires in Lahaina on Maui's northwest coast killed over 100 people. Poor communication and lack of emergency response contributed to the disaster. But these were not the only casualties, and I think this is really important. There was a study released last year by the University of Hawaii called the Maui Wildfire Exposure Study, and it has revealed in the aftermath of that fire acute problems, respiratory problems, hypertension, and depression. And what amazed me when I read that study was almost 5% of the respondents noted that they have considered committing suicide. We need to also consider depression. Nearly one half of the residents of Maui consider their health now worse than it was a year ago before the fires. And I don't need to remind you what happened here in Los Angeles. The Palisades and Eaton fire have burned more than 37,000 acres. That is 17,000 times the size of the Maui fire. So we can certainly expect health issues to come. And as I said at the beginning, everybody has a story, including me and my family. My sister is a kindergarten teacher at Canyon Elementary School. It is 0.4 miles from the burn line. They have been pushed to go back to school and teach. Only 9 of 23 kids in her class have decided to return for fear of health concerns. And this is a picture of my brother's home in the Palisades. 30 years of building memories, 30 years of raising his family, gone in an instant, and bigger concerns other than the financial of moving on and living in a community that has so many health issues. So as I said, these stories, they touch everyone. One of the things that the COVID-19 pandemic laid bare is significant deficiencies in the US public health system. Unfortunately, it also heightened the politicization of public health, which derailed some prior efforts that were making some progress, including things like lack of funding for a resilient, robust public health workforce, the inability to share data across important stakeholders, and lack of funding and support for prevention efforts. We use the term public health system. System is a pretty optimistic misnomer. Unfortunately, what we have is a series of fragmented players and systems that often or really can't effectively collaborate. Even governance and administration is spread across 3,300 state and local health departments. There needs to be a holistic approach, and it needs to include the social, environmental, and economic determinants of health facing our communities. The transformation of the U.S. public health system is critical to the transformation of healthcare, and it's going to require several important things. Like I said, being able to share data and being able to garner the insights for that data to get in front of these issues. We need to empower our workforce and give them the tools and the resources they need to do their job. And lastly, we really need to look at the communication systems. I think what COVID-19 showed us was that there was a rash of disinformation. The way in which we were reaching people was not effective. We didn't have trusted messengers enlisted, and the list goes on, all of which will need to be addressed as we go forward. We've also seen much written about AI, and certainly the promise of AI, which I am a full support of, the ability to drive efficiencies, enhance our understanding of diseases, and accelerate drug discovery. But despite all that promise, there are commensurate perils, and we need to think about those. A significant and reasonable concern with AI algorithms is that they have the potential to perpetuate bias. I would say kind of a garbage in, garbage out, but it really is much worse than that, because we can continue to build and build and build upon those biases and create more inequities. The algorithms themselves can be exclusionary because of the data and the biased data that exists, and also the lack of involvement of people from disadvantaged communities and a wide swath of the population that's representative in the development of the algorithms themselves. One of the key aspects of AI is natural language processing, taking how people speak and write and then codifying that and using that in AI algorithms. And there was one particular system you may have heard that the courts use for sentencing after people have been convicted. And this gets wrong the likelihood of reoffending, which is important in terms of how long the sentence is. If you think somebody has the potential to reoffend, 2 times as often for Black people as it did for white people. But it is not all bad news. And again, everyone has a story. So this is Will Studholme. 58-year-old Will Studholme ended up in 2023 in an emergency room for GI problems. While the abdominal CT scan confirmed that he had food poisoning, something not particularly dangerous, what wasn't expected was a diagnosis of advanced osteoporosis. Osteoporosis, a common illness, particularly around women, older women, white women generally, certainly wasn't expected in him. But by applying AI in the background, what they call opportunistic screening, leveraging the expertise of an Israeli startup, they were able to detect this very simple, common age-related condition in Will Studholme. And it's opportunistic because it takes advantage of imaging that was done for a different purpose and then applied, in this case, to understand another illness that he had. So this is actually almost the exact opposite of bias. There was bias probably. No one would have been looking for osteoporosis in Will Studholme. 58 years old, male, white. He didn't fit the typical person and characteristics of somebody with osteoporosis. But in the end, they were able to diagnose this and get him on a good regimen and have a better outcome. So what is it going to take for this industry to transform? I would argue that it's going to take a number of very significant paradigm shifts, and it's going to take us to look at what I would call the art of the possible. And I want to go through some of that today. What if the consumer was the CEO of their own healthcare journey? Increasingly armed with access to extensive health information and emergent technologies like AI chatbots and things like ChatGPT, consumers can now make decisions around their own health. This historic imbalance of knowledge that existed in decision-making between the doctor and the patient will no longer be a barrier to consumer engagement and empowerment over consumers' own healthcare. In the past, this medical knowledge, of course, was garnered through years of education and schooling, and it was really the gateway for crucial decision-making. But this was largely one-sided. In this image and this paradigm shift, it is no longer one-sided. The consumer has agency and is able to make decisions. Enabling technologies will also help clinicians by unburdening them with administrative tasks, allowing them to play a new role, a role of coach, to motivate, to inspire, to optimize. And practicing at the higher end of humanity, they'll understand individual strengths and weaknesses and health goals and histories, and they'll be able to uniquely adapt to that. More continuous engagement, such as what we've seen in virtual health and retail and wearables, will also move health decision-making to where consumers can make decisions on a day-to-day basis, rather than waiting for that episodic moment where they go in because they're sick. And the shifting ownership of risk, what we've talked about, is we've seen more and more of consumers having to participate financially more through copays, deductibles, HSAs, and other means. They will increasingly demand more engagement. And lastly, of course, consumers have changed their expectations on what they've seen in other industries. Certainly in retail, around more personalization, more real-time engagement, and all of this has been enabled, things like digital technology, and consumers are already bringing that to healthcare. The next big shift that will have to happen is that we need to move from a system that focuses, rewards, treats sick care to a system that encourages, supports, pays for wellness. So this was a Deloitte study that was done recently that showed that the US today spends about $4 trillion on healthcare, everything from sick care to wellness. But as you can see on the promoting health, this is a tiny fraction of expenditures today. This study that included a number of projections and looking at showed an overall industry growth of doubling to about $8 trillion. But if you look at the top right, $3 trillion now focus on health promotion. And so this is, I think, an important sort of concept. It's obviously a model, but I believe that it will happen. And it's going to be ushered in by a number of things. Increasingly sophisticated networks and ecosystems that will enable new services and new intervention provided to patients. This ubiquitous access to data that we've talked about that will fuel everything from artificial intelligence to personalized consumer engagement, and new and expanding applications for AI to predict the onset of disease, to allow for early intervention and accelerate the discovery of treatable illnesses early. And lastly, advancements in genomics will make personalized care possible, such as precision oncology, and will allow us to identify patients at risk much earlier, so there's more early intervention. Next, we really do need to look at what we pay for. You know, what you pay for happens. Right now, we have a system that pays for volume largely. Even though there have been shifts to value-based care, it has been a slow shift. Mostly, our system rewards more care being provided. It mostly doesn't reward prevention. But we need to move to a system where we pay for outcomes, not volume. And that is a shift to value-based payment models. Now, I don't want to underestimate how difficult that's been. That has been extremely slow shift for a number of reasons. It is difficult for providers to manage risks. Access to the data needed and other impediments have slowed the progress in this direction. But we have to continue in this direction. We cannot continue to pay for volume and not pay for value. And I would believe that as consumers get more engaged, they will demand to see the outcomes for the money that they spent. We also need to structure insurance coverage differently, I would argue. We need to look at longer duration insurance plans. So, for example, we all know that insurance is an annual cycle, but we know from our own personal experience that's not what healthcare looks like. You can be well for a couple of years and then have an accident or discover that you're sick and have to go on an expensive drug like Enbrel. We need to look at insurance plans that have that end-to-end longevity that is needed so patients can focus on their health and also be covered when something happens. And in doing so, we also need to look at portability. We have a system where largely health insurance is tied to your employment, and that does not allow for portability. If you leave a job, then you leave that. And that has hurt things like continuity of care and the ability to have longer duration plans. The next, I think, is controversial, even though I think we could all agree to it conceptually, is that we need to structure to drive personal health accountability. We need to consider plans that reward people for health-seeking behavior. Now, there are so many issues associated with something sounding so simple there. There are major equity issues. There's issues around cultural barriers. And there's certainly issues around what is the connection between a health outcome and your lifestyle, and whether or not we can always prove that. And then lastly, I would say that we always on every one of these apply an equity lens. And we must remember that equity is not equality. Equity is not giving everyone the same thing. Our focus needs to be on equitable health outcomes. So much has been said about health equity. And, you know, I thought about what I was going to talk about here, and I know Tony talked about some work that I had done in Kaiser. And I think that in this case, health equity is better explained via story. So I'm going to tell you a little bit of story here. So about a decade ago, I was preparing for a board meeting at Kaiser Permanente. And we were looking at where we were going to place facilities. You said I was running our capital program. And I don't know what made me do this, but I asked somebody to put this chart together for me. So let me go through this. And I will say one thing about this chart. I think I asked her 10 times to make sure it was right. And then she said to me, "Are you sure you want to show this?" Remember, I was running the department deciding where we place new facilities. On the right here is a Southern California market in Orange County. Wealthy market. Average life expectancy, 83 years. Excellent access to good food, housing. And if you look at this, there were about 200,000 patients or so served in this market. In this market, Kaiser Permanente had 11 clinics and 1 hospital. That was about 622 patients for every clinic office. And then there was South LA. For those of you who know Los Angeles, South LA, very disadvantaged. Poor access to food, poor access to transportation, high unemployment, everything that you could imagine, including a life expectancy of 76 years, a difference of 7 years and a 45-minute drive. And I want you to think about that. But then we saw the data. 2 clinics, no hospitals, 11,000 patients per clinic office. I will never in my life forget that moment in that board meeting. And the first thing that was asked of me is, how did this happen? I would have asked me that too. And I turned around and I said, well, it's me. I did it. I mean, I allowed this to happen. It was, it was on my watch. And then I said, you know what? I'm going to change my answer. This happened because we were not making sure it didn't happen. And I want you to think about that. We were not being intentional. There was all kinds of bias built into this. Bias about where physicians wanted to practice, bias around, what constituted a good market, whatever you want to say, there was bias right here staring us right in the face. We had done this. I had done this. We had all done this. But then we had to set out to fix it. And this became a decade-long journey for me. So I want to talk a little bit about this. There was a property that we found in the Baldwin Hills Crenshaw, if you know this area of Los Angeles. It was called Marlton Square. It had once been called Santa Barbara Plaza. This 22-acre parcel had once been a bustling place of business for the Black community. In the 1950s and 60s, there were 200 or more thriving small businesses on this plot of land. And it was a place for commerce, but it was also a place for connection, for community engagement, for friendships. A lot of people spent time there. But as one journalist put it when I was looking this up the other day, the center went into a perpetual development coma for years. The fact is, this 22-acre parcel had faced an all too common history of neglect and broken promises to the community. Actually, if you read about this, there were many people who had come in who had promised things to the community about redevelopment and then had left, and often had left taking money that had been provided for that purpose. So when Kaiser Permanente bought 9 acres and decided to build on this, we did so with a lot of intention. And the thing that we did that I am most proud of is we did this with the community. We didn't do it for them. We did it with them. This $90 million investment was a very significant investment, considering particularly the history of this. So what did we do? We put in walking paths. People told us there was no viable green space in the area. We put in free Wi-Fi, something we take for granted, but at the time people lacked, and so they couldn't conduct business. They couldn't look for jobs. We put in community meeting space because this was all but non-existent in the community. And of course, we put in much needed medical services. But when we asked people what they really wanted, the thing they told us what they wanted the most was jobs. And that's where Charles Slay comes into this story, who's become a good friend of mine and really emblematic of what we were trying to do here. Growing up in the Baldwin Village section of South Los Angeles, Charles roamed the streets as a member of the Bloods. For those of you who don't know, very notorious and very dangerous gang in Los Angeles. The neighborhood he grew up in, right around Baldwin Hills, Crenshaw medical office building that we were to build, was forlorn. It was completely devoid of commercial life. And as Charles put it was easy ground for ambush, in his words. Charles' mother, like so many people in this community, lost his mother when he was 10, leaving him with a father who was in and out of work and really unable to fully care for him. I remember Charles telling me a story when I first met him that when he was, 13, 14, he wanted to join the Boy Scouts, but there was a $16 fee and he didn't have $16. Jobs in this neighborhood were scarce. Good jobs, completely non-existent. Flipping burgers, bagging groceries. There was simply no route out of poverty, and there was no route out for Charles. So at 21 years of age, Charles killed another gang member and went to prison for 27 years. When Kaiser Permanente made a decision to build on this property, we made a decision to reserve a third of the construction projects for people living within the 5-mile radius. And this was not easy. But among them were 70 former prison inmates employed as plumbers, carpenters, and electricians, doing their apprenticeship on our project, including Charles. About 600,000 people every year in the United States are released from prison, and their unemployment rate is upwards of 27 to 30%. 5 years later, after Charles completed our project, he went on to build the Los Angeles Rams football stadium, which I know he was very excited about, got married, and was making over $80,000 a year. That is health equity in practice. That is economic equity in practice. So now we see ourselves in a real call to action. We need to make a lot of progress. We need to make it fast, and we need to make it with purpose. The stakes could not be higher here. How we lead matters. Leading with moral clarity and a clear purpose to improve our health of the communities needs to be our North Star. And we are at a very critical inflection point. So I would offer that the healthcare industry is in need of many things. It is in need of imagination. We cannot approach this industry transformation in the way that we have always done it. We need to bring more creativity and more imagination to the work ahead. We need to look at this through more collaborative models. The healthcare industry and the challenges we face, we cannot do this alone. And as Tony talked about, the collaborations we're seeing across UCLA, I've been involved in some of the innovation challenges across business, law, engineering, the health system, the public health. These are critical to make the kind of progress that we're looking at. This is an industry in need of equity. We cannot, and I know I've said this before in this, view health equity as virtue signaling. We cannot. We need to communicate with clarity that health equity is a moral and a business imperative. It is absolutely required, in my view, for the sustainability of the industry. And we need to approach this work with optimism. Optimism that we can believe that industry transformation is possible, because it is. And we cannot become mired and jaded, even though we know that this has been a very long and difficult road. And this is an industry, I would argue, in need of healing. We have to rebuild trust. This industry, as so many have lost trust from patients, providers, and particularly from our underserved communities. And in a lot of ways, this industry may have to be unwinded, which is probably the hardest here, because the very system that we have may impede our progress, and we will have to have the fortitude and the conviction to do that. And lastly, I would say that this is an industry in need of reinvention. We must heal our communities. We cannot accept health outcomes that differ purely by the zip code that you live in. We cannot turn a blind eye towards discrimination and the inequities that exist in our healthcare system. We need to design new systems and business models that reward value and outcomes, not just volume. And we need to prioritize wellness and prevention. We can't accept that 12% of Americans have diabetes and almost 100 million are pre-diabetic. And we cannot politicize the healing of our planet, and we cannot convince ourselves that the health of our communities through environmental issues is not facing an existential threat. So some have suggested that this is our Sputnik moment. Now, maybe you're a little young for that, if you remember. So, this was the space race between the United States and Russia. And with the transformative potential of AI, we actually may be what feels like a Sputnik moment for us. But realizing our collective potential is going to require that we accelerate innovation, and we accelerate the adoption of that innovation in the industry, which is not easy. We know that the global health system has been absolutely pushed to its limit. We know that exponential change will be driven by accelerated technology development and adoption. So we know that it is possible. And we know that our capacity for ingenuity, if unleashed, could do amazing things. Innovations like precision medicine will allow us to better target disease, and we'll be able to put healthcare into the hands of people through innovations such as wearables. And physicians will be unburdened by helping them with their administrative tasks. So they will be allowed to spend more time on healthcare, and we'll arm them with the insights that allow them to do faster and more accurate diagnoses. Sensors will allow people to age in place, which will become so critical as our population ages. And cutting edge approaches like mRNA, we've already seen what they can do for vaccine production. But now we see other advancements in vaccine formulation, including nanoparticle technologies, which pave the way for multi-pathogen vaccines to protect against multiple diseases in a single shot. A myriad of partnerships will be required to realize this. Cross-industry, we've talked a lot about industry convergence over the years, the government and the private sector. And I would say also that we need to unleash the potential of clinical entrepreneurs sitting in our midst in health systems who understand firsthand the issues and how to solve them. And we must do all of this with a sound moral and ethical compass. So I want to tell you one last story. And this story, it's about all of us. This one, no one's exempted from. We're all actors in this story. We're all casualties in this story. And I want you to think about the implications of the following video that I'm going to show you. This plots U.S. health expenditures against life expectancy from 1970 to 2021 and compares that to other developed countries. See what happens over this 51 years. Realize how much innovation occurred during that 51 years already, how much money we've spent on our health system. And think about why it looks the way it does. And think about the impact on our country, and think about the impact on you, and think about the impact on generations to come. So I just ask one last question of all of you. What are the stories that you will tell the next generation? Thank you.
We now have a couple of minutes for questions. Please raise your hand and we'll get a mic runner over to you so you can please ask your question.
Good morning. Thank you so much. Great presentation. I'm wondering, what are your thoughts on aligning incentives?
Yeah, I do. I mean, we've talked here about value-based payment models, and they have been very slow. For those of you who don't know, this is really, Kaiser Permanente is sort of the ultimate in value-based payment models where the physician or the group is paid a certain amount and they are sort of compensated, they manage risks, and they're paid for outcomes. And we've seen a lot of it. We've seen it through Medicare 5-star. We've seen it through other things. It's making progress, but it's not making progress at the rate that it should. There's still too much, I think, fragmentation in our systems, although there is more and more alignment between providers, I think, than we've seen. So I'm a big fan of it, but they have to be the right incentives. And I think we have to understand, we're actually doing a little work right now for an integrated health system, looking at how is value generated and actually asking the question, like, what really drives value? And I think that's part of it too, is what are the right incentives? Because I think that's also been an impediment of people saying, well, you want to put an incentive to reduce, the cost of diabetes, and then you run the risk of there's a larger percentage of people of color with diabetes. So it sounds a lot easier said than done, but I just don't think we can give up on that journey. I mean, I just don't, because right now we're paying for a system that really doesn't reward the outcomes. however we measure them. And I just think that's something we just can't accept. But it's hard, as you probably know. Any other questions?
Thank you. It has been mentioned the fast pace of technology, and there is so many medical devices or helpful systems. So the European Union has the medical device regulatory, so it's reimbursable. Is it also in America? Do you see it coming in the next years, also for Kaiser? Or what was hindering to have those medical devices or apps and so on to have reimbursed also in the medical system?
You're talking about like the regulatory environment. I mean, the regulatory environment for me, will need to change. I mean, it's here for a reason, of course, to ensure safety, but I do think it's been an impediment to innovation. I think that's going to have to change. I mean, it's just my personal opinion that we're going to have to be able to unleash this innovation faster. And part of that impediment is the regulatory environment. I think it's going to have to change. Will it? We will see. We have a new day, so we'll see what happens here. But.
Is it on? Thank you so much for this wonderful keynote. Question behind this very disturbing chart, the data behind it, right? What is your take on the biggest driver of this exponentially rising health expenditure costs per capita in the United States as compared to the rest of the world, while not, accomplishing the health outcomes we're hoping for?
Yeah.
Thank you.
I think it's a lot of things. I mean, I do think that we do not have equitable access to healthcare, and we just see the differences in outcomes between different populations, particularly when they differ socioeconomically. I do think that universal access to healthcare insurance is not a privilege in this country. I think it's a right. I really do believe that. And we need to figure out how to structure that. It impacts not only people's access to healthcare, but just the whole risk pool and everything that goes if only certain people can. And we've just really deprioritized the health of our country. I mean, I just, like some of the things going on in Washington or not, one of the things that I think is heartening is a discussion about the health of our country, which is really not good and drives a lot of, particularly around diabetes, which is just rampant in the United States. So I think it's incentives, it's lack of access. I think the equity issue is very serious. And I think the overall accountability, personal and support from institutions on helping people live healthier lives, the food supply, all of that. It's really multifaceted. This didn't happen. This happened over 51 years when you see this. It's very significant. And what you saw at the end, by the way, that dip, that was COVID. That dip in 2021 was COVID. And that was a lot about our public health system, how we responded as a country, how we politicize the disease and all kinds of things. So we are both, we have to all be part of this solution, including literally every one of us, but it's so multifaceted. And that's why when I talk about this need for unwinding and reinvention, I use words like that on purpose, because I think this tinkering on the edges is really creating this. Yeah.
Oh, yes. Sorry, one more question.
Sorry.
I'm really intrigued with the slide that you showed about comparing South Los Angeles with another Southern California county in terms of access to health resources. And certainly not a problem that's unique to Southern California. Are there any things that you've seen that are more effective at addressing this issue, whether it's like a certificate of need state, like more like regulatory versus industry incentive?
When we did this project, we actually, so I probably shouldn't say this, Tony, but we worked with Michael Porter at Harvard Business School on this notion of shared value strategy, which is a very simple construct of looking at this intersection between what's good for business and what's good for society. And it was just really interesting because when we did this at Kaiser, my argument was that sweet spot, that doing good business at Kaiser and doing good for society wasn't as small as we thought. And that by finding that intersection, we would create something very sustainable. And so this included the real estate development. It also included things like supplier diversity, and who we were purchasing goods from. And it layered and layered on. And it became a very durable strategy, which is not easy, right? Corporate America, a lot of strategies come and go. This became an extremely durable strategy. It continues to this day. And I think at the end, that became better than any sort of government imposed, because we understood that we could do good business and do good. And once people understood that and understood the examples, it started growing. So I personally believe it's a better strategy than kind of a, sort of a punitive, kind of thing.
Thank you so much, Jodie. We've prepared a small token of our appreciation from the HVA. Thank you so much for coming.